I'd like to invite Dr. Rishi for speaking on cataract surgery in endothelial keratoplasties.
At the outset, I'd like to thank Dr. Mona for involving me in this lovely IC. All the talks have been really good, and I hope you find this useful. So the topic given to me is cataract surgery and endothelial keratoplasty. So it's a very focused topic, and I'll try and just give some of the important tips when dealing with the situation of a cataract in a patient who's either already had an endothelial graft or is in need of an endothelial graft simultaneously with the cataract surgery. So I'll describe both the situations. When you're talking about a combination of a cataract surgery with endothelial graft, that is called an EK triple, and that could be a combination with either a DSEC or a DMEC. The first situation is cataract surgery after an endothelial keratoplasty. So either the patient has had a DSEC or a DMEC. If the patient has had a previous DMEC, the surgery is pretty much just like it would be in a virgin cornea. You don't really have to make any separate things, except that your endothelium is precious, so you want to preserve the endothelium. So the approach to your cataract surgery will be like it is for any patient with a maybe an endothelial deficiency like a Fuchs. So you will probably use a soft shell technique or a viscoadaptive OVD to protect the endothelium, and repeated injections of OVD in between your steps of cataract surgery. Ideally, you would like to make your entry outside the DMEC graft, but I don't think it's mandatory. It's very unlikely that your phacoemulsification will detach the DMEC graft. Rest of the surgery is pretty much normal. Even IOL calculation in DMEC, you don't really need to make much of an adjustment because it doesn't really have much of a refractive effect, the DMEC graft, unlike the DSEC graft, which causes a hyperopic shift, so you have to choose a more of an endothelial, more of a myopic power. When doing phacoemulsification after a DSEC, you have to keep some things in mind. One is your entry wound. So if your graft is well centered, then probably it may make sense to do a scleral tunnel, and always try to enter outside your graft. If it is a decentered graft, choose the side where you have more working space so that your entry is away from the edge of the graft or away from the DSEC graft per se. Sometimes you will have some posterior synechia or peripheral anterior synechia in DSEC, and it's important to use this opportunity to also release those attachments. Otherwise, sometimes after surgery, those synechia can increase, and it can even trigger a graft rejection. When you're doing the rhexis, sometimes the visibility may not be very good, and it's important to get a good rhexis. So, especially if you have some interface haze or any irregularity in the graft. So don't hesitate to take off the epithelium if that helps to improve your view. You can use other illumination techniques like the endo illuminator, like was mentioned by the previous speakers, and use of repeated dispersive OVD on the surface of the cornea also would help. Rest of the steps of phacoemulsification are routine, except that again you want to approach this case like a case with a precious endothelium, because it is precious endothelium. You have an endothelial graft there, and we know that even if the graft is clear over time, most of these corneas do lose a lot of cells, and sometimes you may have a clear graft with as low as 500 or 600 CD count. So just try to do an in the bag slow motion phacoemulsification, repeated injections of OVD. Try to direct your phaco tip away from the endothelium, so you might want to just either face it downwards or sidewards, and make sure that every time you're introducing your phaco probe, try not to go in with irrigation on. Sometimes the flow of your irrigation can also detach the edge of the graft, which is something you just don't want to end up with during a phacoemulsification in a post-DSEC eye. The other thing to keep in mind is in case this patient is going to likely require another endothelial graft in future. So this is just to show that sometimes if you can't see well, don't hesitate to take off the epithelium. So I could see, but I was a little unsure when I was doing the IA. So rather than have a PC rent because of poor visibility, I'd rather just take off the epithelium and let it heal later. So that's what I did in this particular case, and you can see the visualization suddenly got a lot better. So in this case, I'm using a silicon tipped IA probe, so it's very gentle on the capsular bag. So even if you accidentally catch something, you won't really rip the PC. These are disposable IA tips. Intraocular lens, keep in mind that if this patient is likely to require another DSEC or a DMEC in the future, you probably want to avoid a hydrophilic acrylic lens. In this particular instance, I'm actually using a hydrophilic lens, but in general, it's a good idea to go for a hydrophobic or a non-hydrophilic lens, because hydrophilic acrylic lenses, when they come in prolonged contact with air, they tend to have calcification, and often this calcification is bang in the center of the optic, and that will affect the vision of the patient, and sometimes you have to go and change the lens. So it's really an exercise in futility, and you probably are best doing a hydrophobic lens. And the second thing is the IOL power. Like I said, always choose a little myopic power, because the shape of the DSEC lenticule is like a concave lens, and it will induce about 1 to 1.5 diopters of hyperopic shift. So that's about cataract surgery in a patient who's already had a DSEC. When you're combining with triple procedure, so it could be a DSEC triple or a DMEC triple. Some important points: remove the epithelium to improve your visibility, like I showed in the previous this thing. So don't hesitate to do that. Always use a cohesive OVD in a triple procedure, in an EK triple procedure, because if you leave dispersive OVD in the AC, it can prevent adhesion of your endothelial graft, and the dispersive OVD can come in the interface and even cause haze. So that's a very, very important thing that you have to keep in mind. Descemet membrane stripping is not really necessary in a PK, post PKI like in this case, but in a routine case, of course, you probably want to do. So this is a failed PK for a therapeutic graft in which we did a DSEC triple. IOL power adjustment I already mentioned. DMEC, aim for emmetropia. If it's a DSEC or DSAK, aim for slight myopia, about 1 to 1.5 diopters. And like I said earlier, avoid hydrophilic acrylic lenses because of the risk of calcification. So I'll just show some videos. So you can see this is a patient with pretty bad hazy cornea. So Fuchs endothelial dystrophy with cataract, and we're doing a triple procedure. So you can see, because visibility isn't so great, it's a good idea to actually take off the epithelium in such a case. So we put in the OVD, but can't really see so well. So we took off the epithelium, and then you can suddenly start seeing a lot better. You can suddenly all the details of the cataract are visible. Now, one more important thing to do in these cases is, if your visibility is still not great, don't try to do an in-the-back phacoemulsification, because anyway you're changing the endothelium. So pick up the nucleus pieces, bring them right next to the endothelium and emulsify them there, because it doesn't matter. You're going to change the endothelium. You don't worry about the endothelial damage in this particular instance. And again, hydrophobic acrylic lenses are better than hydrophilic lenses, and you have to do a good removal of the OVD, avoid the cohesive dispersive OVD, like I said. So after you've put in the lens and before you take off the OVD is when you actually take off the Descemet membrane. So in this case we are using a reverse Sinski hook to just score and strip the Descemet membrane. You can see it coming off. It's a good idea to mark the surface and do a well-centered removal. In this instance I didn't do that. I like to do a push-in DSEC, but you can use whatever technique you like, including pull-through or even tachofold. So I just put like a blob of OVD and slide it into the AC through a clear corneal incision. And after the graft has been attached with air, you can do these kind of venting incisions to remove the interface fluid and allow for good attachment of the graft. You can even center the graft through the venting incisions. Okay, you can also combine your DSEC with a manual small incision cataract surgery if you've got a really hard cataract. So that's what I'm doing in this particular case. It's a grade 4 cataract with Fuchs. So again, removing the epithelium to improve the visibility. you can see it's almost a brunescent to black cataract. I think it's a cataract and nigra, in fact, yeah. So you can see that I've done a large rhexis, prolapsed the superior pole of the nucleus out, and then basically once you've, I'm sorry, in this particular instance, I took off the DM first, but you could also do it after your intraocular lens is implanted. So this video should have come earlier, and then the nucleus removal. And then finally, after you've implanted the lens, you put in your DSEC graft. In this instance, I'm pulling it in with the forceps, but from the same side. So it's like a push-in DSEC. Finally, coming to the DMEC triple, again, principles remain the same. You sometimes may have poor visibility, so whatever steps you need to do to improve your visualization, use of an endo illuminator, removing the epithelium, etc., you can do. As you can see, I'm doing that now after I've partly done the phaco removal of the nuclear pieces. I'm doing the cortex removal with better visualization after removing the epithelium. Sometimes as you go into the cataract surgery, the cornea becomes more hazy, and you may need to remove the epithelium later because it's become more hazy and you can't see anymore. So in this instance, after implanting the lens, I'm taking off the DM. You can see it quite clearly in this video. And after that, basically, you put in your DMEG scroll. Okay, so you can see that the scroll has gone in. When you've injected, make sure you give some counter pressure before you remove your injector, DMEG glass injector, because otherwise the DMEG graft can follow it, and you'll suddenly have a graft outside the eye. Then you have to do all these tapping maneuvers, which are typical of DMEG, to kind of try and unscroll the edges of the graft. The graft is always endo out, so the edges can be curled in, and sometimes that can be a little bit of a challenge. So in this case, we are pinching the center of the graft with one cannula and using tapping or decompression maneuvers to kind of unfold the edges of the graft, and gentle tapping to recenter the graft. So you can see there's a mark, F mark on the graft as well. So once your graft is fully unfolded, you can go in with a small 30 gauge cannula, put in a small bubble of air, and then you basically enlarge that bubble in 2 or 3 small steps. You don't have to come out. So once the whole graft has been covered, then this is a good way to kind of make sure that the air doesn't leak out. You put it tangentially to the side of the side port, and that kind of closes your surgery. So cataract surgery in the setting of endothelial keratoplasty requires special attention and specific modifications to standard technique to have a safe and effective outcome. Pay attention to selection of lens power, material and design. Respect the graft and endothelium while performing cataract surgery after any keratoplasty. Thank you.
Videos.